committee. Good afternoon, welcome, and sorry to start late. We will come to order and begin with bill introductions. Would recognize Representative Neighbor.
Thank you, Mr. Chairman. I would like to introduce, it's a pharma bill that we actually had last year, and there has been since then a Supreme Court decision that would help with a lot of the clarity, and the RS number is 2021-0902.
Committee questions? Is there an objection to the bill introduction? And without objection, the bill is introduced. Thank you, Representative. I would recognize Doug Jorgensen with the Fire Marshal.
Sorry. My name is Doug Jorgensen. I'm currently the State Fire Marshal, and this bill would increase the amount of revenue we receive from the insurance premium levies that are collected across the state from insurance companies that do business here. We currently receive about 0.8%. This would raise it 0.2% to a full 1%. And it's basically the only funding for our office are the insurance premium funds. We receive no SGF funds. And the RS number is 21 RS 0897.
Thank you, committee. Are there any questions on the introduction? And is there any objection? Without objection, the bill is introduced. Thank you. I also have one. It is RS 817, so you can tell I've needed to do it for a while and haven't gotten it done. It deals with a review of the actuarial timeframes where the CAPERS board could select up to 5 years rather than 3 if they felt it was appropriate on some of the experience studies and other. But are there any questions on the introduction? Is there an objection? And without objection, the bill is introduced, RS 817. Other bill introductions? Seeing none, I would just make it clear, we are at the end of the rope on bill introductions. Monday would be the last day in committee to introduce a bill in a non-exempt committee. So if you have another idea, it's time to get it on the table. So thanks, committee. With that, we'll move into our first item of business, which is actually an item of business I should have completed before. If we go back to Bill 2064, one of our conferees, the folks from CAPERS, had clearly mentioned a few things that were concerns to address in that bill. And I needed to remember that there is a balloon that we should consider. So given that I would like to consider that, we did not turn in the committee report, and I have asked that the committee might consider whether to reconsider House Bill 2064, and I would ask the Vice Chair for a motion.
Thank you, Mr. Chair. Having voted on the prevailing side, I move to reconsider the committee's action to report on House Bill 2064.
Moved by Representative Cross, seconded by Representative Miller, although I had a couple good choices there, so thank you. So with that, we would reconsider, and I would look to why we want to reconsider, and Representative Croft. Absolutely. I had a motion to reconsider and I didn't take a vote. Thank goodness somebody is paying attention. So I don't even know if the motion to reconsider is debatable. I believe that it is. I'm going to allow it until the reviser tells me it's not debatable. Is there any question or discussion? Seeing none, those in favor of the motion to reconsider, please signify by saying aye.
Aye.
Opposed, nay. Ayes appear to have it. Ayes do have it. And finally, we're where I thought that I should be to start with. So thank you, Representative Croft, for reminding me where I was in the process. And with that, we would look at why, which would be a motion to amend. Representative Croft.
Thank you, Mr. Chairman. I have an amendment. It is a technical amendment, and if you'll distribute the balloon amendment, please. And while you're doing that, just the 2 points to it. One is it talks about, it addresses requiring employer and employee input. And the second one is requiring consecutive drop period in conjunction with the first election, because the IRS will not allow a interruption in that process.
So I have the motion by Representative Croft to amend. Is that a second, Representative Toplicker? Or is that a question?
Mr. Chairman, it is, I'll second, and I also had a question on the location of that. Did you, or we emailed that, or was that on the,
So thank you, Representative Toplicker. It's a good question. So the thrilling, right, the thrilling part of the balloon amendments is they get emailed to you when they are offered. So it's a little more challenging to get through. Just as in a committee, it would otherwise be distributed to us on paper. The downside is go into your email, look for Jan's name, and next to that, she had it to us directly. So hopefully you can either see it on the screen or on your screens now, but I don't know that that process will change. I think as we get amendments, they'll continue to come as a balloon at the time that they are offered, and be ready to grab that on your computer. With that, because the explanation I know was thorough and everybody knows exactly what it does already, I might ask if the director from Capers would more thoroughly state what concerns we have and why we would like to take this step.
Thank you, Mr. Chairman. Yes, your Vice Chair Croft has done a good job explaining it. One, it just keeps us square with the IRS. They have, our IRS Tax Compliance Council has opined that if there was a break, and let's say the member just went back to work for a couple years and then wanted to maybe serve out, enter back in for another 2-year drop period, still to stay under that 5-year cap. From the IRS standpoint, it's believed that would be an in-service distribution, which is not permitted under the Internal Revenue Code. And so this part of the amendment would address that to keep us square with the IRS. The other part, currently the drop program, it's a shared agreement between the member and their employer, in this case, the Highway Patrol and the KBI. In terms of the extension, this language would clarify that it would continue to have to be a shared agreement between the member and the employer.
So thank you for the explanation, and if I'm counting right, it is 7 words to add, and that's about as concise as we can to achieve 2 pretty big things with those 7 words. With that, committee, are there any questions? Yes, Representative Riley.
Thank you, Mr. Chair. Remind me, when we sent this out, did we send this out to go on the consent calendar?
So thank you. We did not use the consent calendar. We had just sent it out, but the report was not yet finished by the reviser. We were made aware of it immediately, so it was passed out, but I did not turn the report in on the floor, so we didn't have to have it re-referred, and we had the chance to reconsider the action here in committee. So thank you. We haven't used the consent calendar since the first day when I moved wrong and slowed up the RBC until the 3rd week, which would probably have already been taken care of if we had not taken that step. So anyway, questions, committee, Representative Miller.
well, just point out that if we amend it, it wouldn't be eligible for consent.
Thank you. Further questions or comments? Look to the other room or change the screen. Great. So thanks, team. With that, if there is no further discussion on the amendment, Representative Croft, you may close.
Thank you, Mr. Chair. I close.
You've heard the motion by Representative Croft to amend House Bill 2064. All those in favor signify by saying aye. Opposed, no. Ayes appear to have it. Ayes do have it, and the bill is amended. And that puts us back on the bill. Representative Croft.
Mr. Chair, I move that House Bill 2064 out favorably as amended.
Seconded by Representative Neighbor. Discussion on the Croft motion. With no discussion, I'll just let you say I close.
Yes, sir. I close.
You've heard the motion by Representative Croft to pass House Bill 2064 favorable as amended. Those in favor, please signify by saying aye. Opposed, no. Ayes appear to have it. The ayes do have it, and the bill is again passed back out. Thank you to everyone for their work to come back on this item. That would take us to our next item of business, which is House Bill 2134, which related to the credit for reinsurance. And I might ask the committee their wishes on this, but we would start, if we could, with an overview from the reviser.
Thank you, Mr. Chair. Can you give me just one moment, please?
Absolutely.
Thank you.
Sorry to not give you more of a heads up on that before we jumped right in.
This is what happens when you catch the reviser multitasking. She gets in trouble.
Well, while the reviser is working on that, I'll share a couple of thoughts just with the committee. I looked at the bills that are in our committee at this point, and we have gotten both the RBC bill and the credit for reinsurance bills now from the Senate. I don't know exactly what form they're in, but we may look at how we handle those. I think we will proceed with our bill as we had planned. Having those other bills may give us opportunities for some flexibility in the future with process, but they are currently fairly similar to the language we have, although we haven't combed through them to see if they're identical. So anyway, with that is our reviser.
I am ready.
Great, back to you.
Thank you, Mr. Chair. Good afternoon, committee. My apologies for not being quite on the spot and ready to rock and roll, but House Bill 2134 is, as the chair mentioned, the credit for reinsurance bill. It would create one new section of law, and it also amends KSA 2020 sub 40-221A, 40-3302, 40-3304, and 40-3306. Section 1 is the new section and would create new law by codifying the National Association of Insurance Commissioners Credit for Reinsurance Model Regulation into statute. Section 2 amends KSA 2020 sub 40-221A. That's our current state credit for reinsurance statute itself. Section 3 amends KSA 2020 sub 40-3302. That's the definition statute of the Insurance Holding Company Act. We added two definitions to the statute of group-wise supervisor and the internationally active insurance group. And then Section 5 amended KSA 2020 sub 40-3304, also of the Insurance Holding Company Act. And this pertained to controlling persons of a domestic insurer seeking to divest or acquire controlling interests in a domestic insurer and filing confidential notice of the proposed divestiture or proposed acquisition of controlling notice, filing that notice with the commissioner and obtaining pre-approval.
Thank
And
you
I can
for
answer
the
questions.
Thank you for the overview. Committee, any questions for the reviser? We believe seeing none, and hopefully we're now at a volume level where we are not hurting any eardrums in our either room. I would ask the committee's wishes on 2134. Representative Croft.
Mr. Chair, I move the committee pass House Bill 2134 favorably.
Motion by Representative Croft. Is there a second? Seconded by Representative Dodson. Committee questions or discussion? And I'll take an extra moment in case there's a wave really huge in the second room. If you have any questions or discussion, I can see the small one up there. Representative Berquist.
That was a wave of all clear here, sir.
Oh. Thank you, Representative Berquist. I appreciate it. Representative Miller? Oh, that was the all clear wave? I'm going to eventually learn the signs, although I think part of the goal is to keep me confused on that. But anyway, short of that, if there is no discussion, Representative Croft, you may close.
Thank you, Mr. Chair. I close.
Heard the motion by Representative Croft to pass House Bill 2134 favorable. All of those in favor signify by saying aye. Aye. Opposed, nay. Ayes appear to have it. Ayes do have it. Thank you, committee, for taking up those items. That sets us up to start learning about some other topics that we can address. And in particular, one of those is a framework to consider those concepts that would be mandates on the law. And for that, I would like to turn it over to Melissa Rennick with the KLRD.
Good afternoon, Chairman Johnson and committee members. Today's presentation will provide an overview of the Kansas health insurance mandates, including requirements in Kansas law, as well as a discussion of recent and proposed legislation. A copy of the legislator briefing book article on this topic has been provided to you and is available on the KLRD website as well, and I will be referencing it in my presentation today. So let's begin with what is a mandate. Just looking at some of the terminology in law. These are statutes that are added in insurance law that mandate certain healthcare providers either be paid for services rendered, or what we term a provider mandate, or be paid for certain prescribed types of coverage or benefits. And these are called benefits mandates. And I thought it would be helpful. I have a representative mandate to show you here. Okay, so I believe you all now can see a bunch of color. It is not printed that way in statute, but I thought it would be very helpful for our review. This is KSA 40-2,166A. It is a result of 2001 law and relates to osteoporosis. And so this is a really, it's diagnosis, treatment, and management. And so this is language you will commonly see in a bill that carries what is called a mandate or required insurance coverage. And you will see first in the blue text, this is any individual or group health insurance policy, medical service plan, contract, hospital service corporation contract, other hospital and medical service corporation, fraternal benefit society, health maintenance organization, and most importantly here would be also municipal group funded pools, so your local units of government, and your state employee health care benefits plan that provides coverage for these services that's delivered, issued for delivery, amended, or renewed. So this is essentially saying these are the types of health insurance policies and plans that would be subject to this benefit if enacted. The date is important. The date prescribed in this particular law was July 1st, 2001. So that would apply to all policies that were issued, delivered, amended, or renewed after that date. That gives an opportunity for insurance companies to provide notice to consumers and to make adjustments for the reimbursement that may be associated with this particular mandated coverage. you will see in the green language, the benefit is properly described. And so that would be coverage for services related to diagnosis, treatment, and management of osteoporosis when such services are provided by a person licensed to practice medicine and surgery in this state. That would be individuals who are termed either medical doctors or doctors of osteopathy. For the individuals with a condition or medical history for which bone mass measurement is medically necessary for such individual. The mandate also is very clear to prescribe requirements on contracts or policies. It just makes it clear that this policy provision or plan amendment or agreement must be applicable to services in the same way to deductibles, co-insurance, and other limitations that already apply in that policy. And then paragraph B, which is the remainder of the text, tells you which policies it would not apply to. And I'll talk with you about that here very shortly, what those might be. So in looking at that kind of policy, then the question becomes, the next question would be, if enacted, what health plans and policies would be required to comply with a mandated coverage like this requirement for osteoporosis? This is an important distinction. These would be your individual health insurance policies that are issued or renewed in Kansas and group health insurance policies issued or renewed in Kansas. And as you saw from that list in this in the law, they also apply to health maintenance organizations or HMOs. And generally, the state employee health plan is also included in such proposals. Just as important as who is subject in terms of health plans, also the question comes up, if enacted, which health policies and plans would not be required to incorporate this requirement into their policies? Self-insured health plans are one of the largest groups that would be exempted from requirements of a Kansas mandate. These would include association health plans, those plans that are subject to ERISA or the Employee Retirement Income Security Act of 1974. The way to look at this is self-insured plans are generally governed by federal law and are enforced, those mandates would be enforced by the U.S. Department of Labor. States are not permitted to regulate self-insured plans. In addition, those would include, and you saw some of these entities listed, supplemental benefit policies. So those policies that are purchased for a specific benefit like dental care or vision plans would not be subject to a health insurance mandate. And also short-term limited duration plans may not be subject to this mandate. I would also note that other government payers would not be subject. So that would include Medicaid and TRICARE and VA benefits. So again, this really gets back to those individual health care and group health insurance policies that are renewed in Kansas. Another way to look at it might be what you would call fully insured plans. That's a way to look at that. And again, one of the largest plans would be the state employee health plan. The next part that I want to do is review from the memo itself. So I'm going to pull back up a different document here and share again. So now we are looking at, in the article, the legislator briefing book article on page 2, a list in table A of all current provider and benefit mandates. Since 1973, the legislature has added new statutes to its insurance law that mandate either those healthcare provider mandates or those healthcare benefit mandates. The first mandates enacted in Kansas were on behalf of the healthcare providers. You will see those on the left side, and note that those are the older mandates that appear in Kansas law. In 1973, optometrists, dentists, chiropractors, and podiatrists sought and secured legislation directing insurers to pay for services as those services were already being reimbursed for by an insurance company if those had been performed by that practitioner of healing arts. And again, that would be either a medical doctor or a doctor of osteopathy. So this was a reimbursement equity issue, and these providers sought and received a mandate that would give them similar treatment for reimbursement of their services. In 1974, the psychiatrists, make sure I get back here to here we go. Psychologists sought and received approval of reimbursement for their services on this same basis. In that same year, the legislature also extended the scope of mandated coverage to all policies renewed or issued in Kansas by or for an individual who resides in or is employed in this state. And that's simply known as extraterritoriality, just making certain that that would also apply the scope of those mandates. Licensed social workers obtained a mandate in 1982. Advanced nurse practitioners received recognition for reimbursement for services in 1990. And in 1994, pharmacists gained inclusion in an emergency pharmacy network approach in terms of how pharmacy benefit and services were being provided to insured persons. Looking to the right column, the legislature also began considering benefit mandates in the early to mid 1970s. The first benefit mandate that was passed by the 1974 legislature required coverage for newborn children. The newborn coverage mandate has been amended to include adopted children and immunization, as well as a mandatory offer of coverage for the expenses of a birth mother in the instance of an adoption. The legislature began its first review for a mandate or coverage for alcoholism, drug abuse, and nervous and mental conditions in 1977. The law enacted that year required insurers to make an affirmative offer of coverage, which could only be rejected in writing. This mandate has been broadened over time, and first by becoming a mandated benefit, and then as a benefit that had minimum dollar amounts of coverage that were specified in the law. In 1988, mammograms and pap smears were mandated as cancer patients and various cancer interest groups came to the legislature to make the requests for mandatory coverage by health insurers. In 1998, male cancer patients and cancer interest groups sought and received similar mandated coverage for prostate cancer screening. And after several attempts, supporters of coverage for diabetes testing and supplies were successful in their securing a mandatory coverage, and that also included educational cost as well as self-management. And so I just note there, you will see, and this is important when you look at the timeline that we're next going to talk about some of those changes that were occurring between 1995 and 2001 that had some changes in approach to mandates that were offered by the legislature. So in looking at this article, the next step begins on page 3 of what you have in front of you. And the question to ask is, are there requirements on the review of mandated coverage or on the parties that are seeking coverage for a new benefit or for either a benefit or a provider mandate? And legislative review is a part of this process. Kansas law in KSA 40-2249A requires the legislature to periodically review all state mandated health insurance coverage. KSA 40-2248 requires a person or organization that is seeking coverage for a specific health service, disease, or providers of healthcare services as part of either this individual, group, or blanket health insurance policy to submit what is termed an impact report. This report assesses both the social and financial effects of the proposed mandated coverage to the legislative committees assigned to review the proposal. The law also requires the Commissioner of Insurance to cooperate with, assist, and provide information to any person or organization required to submit this impact report. The social and financial impacts that are required to be addressed in this impact report are outlined in KSA 40-2249. The complete list is found also on page 3 of the briefing book article, and I'm going to highlight a few of the social impact factors and then separately the financial impact factors. Among those factors that should be provided at the time of consideration of a health insurance mandate would include the extent to which this treatment or service is generally utilized by a significant portion of the population, the extent to which such insurance coverage is generally available, If this coverage is not generally available, the extent to which the lack of coverage results in an unreasonable financial hardship on persons needing treatment, the level of public demand for the treatment or service, and the impact of indirect costs, and those would be other than premium and administrative costs, on the question of the cost of benefits of coverage. In terms of financial impact, those factors appear on page 3 in the right column of the article, and this could include the extent to which the proposal would change the cost of the treatment or service, the extent to which this proposed coverage might increase the use of the treatment or service, as well as the impact of the proposed coverage on the total cost of health care. Next, we look to the State Employee Health Plan. The State Employee Health Plan is a representative health plan that gives quite a bit of data, particularly claims data and utilization information regarding its participants. A reminder, this would include not only state employees, but it could also include spouses and dependents. And so it's a very large group to be considered when a mandate is being reviewed by the legislature. In KSA 40-2249A, in addition to those impact report requirements, there is a requirement that any new mandated health insurance coverage approved by the legislature would only apply to the state health care benefits program, or what we know as the State Employee Health Plan, for a period of at least 1 year, beginning with the first anniversary date of the implementation of the mandate following its approval. On or before March 1st, and this is a deadline that is set to recognize the work of the Kansas legislature, on or before March 1st, after this 1-year period has been applied, the Healthcare Commission, which is responsible for oversight of the plan, is required to report to the President of the Senate and the Speaker of the House of Representatives the impact this new mandate has had on the plan, including data on the utilization and costs of the mandated coverage. This report is also required to include a recommendation of whether the mandated coverage should be continued by the legislature to apply only to the State Employee Health Plan, or whether additional utilization and cost data are required. More recent review of legislation and enacted law relating to coverage provisions are found on Table B, and that's pages 5 and 6. In terms of legislative review, again, referring back to KSA 40-2249A, in 2009, the House and Senate Insurance Committees received a briefing during the session and reviewed not only those mandates in current law, but those mandates that had been recently proposed. And then the next series that we're going to look at takes us from 2009 to the present, and we'll look at information on a trend that's been emerging of what is termed in the article as the study before the law. I would note that this trend continues to be seen among bills that have been introduced in the 2021 session. So a reminder, as prescribed by that 1999 statute, a mandate is to be passed by the legislature, applied to the plan for at least 1 year, and then a recommendation is to be made about continuation in either the plan or statewide. In 2008, legislation directed the Kansas Health Policy Authority, which at the time was the state Medicaid Finance Agency and Oversight Agency for the administration of the plan's benefits, to conduct a study on the impact of extending coverage for bariatric surgery in the plan. And there was also corresponding legislation that had been introduced in the legislature. I would note that no legislation requiring treatment for morbid obesity was introduced during the 2009-2010 biennium. Also, in substitute for House Bill 2075 in 2009, it would have directed the KHPA to study the impact of providing coverage for colorectal cancer screening in the State Employee Health Plan, the affordability of such coverage in the small employer, business employer group, and the state high-risk pool, which is no longer in operation. There was corresponding legislation that was introduced, Senate Bill 288, and which was also introduced as House Bill 2075. Moving to the 2010 session, the House Committee on Insurance considered the issue of reimbursement of services provided by certain Behavioral Sciences Regulatory Board licensees. And there were 3 bills introduced on this topic, and the House Committee recommended a study by the KHPA on the topic of requiring this reimbursement. And you'll see some information there in the article of what the study design would have included, and that included data on utilization, amount of premium charge, some of those things that would have met either the social or financial impact requirements. There was also under Senate Bill 388 a requirement to conduct analysis to determine if proactive mental health treatments results in reduced expenditures for future mental health and physical health care services. That bill died in conference committee, and the study requirement became part of a proviso in an omnibus appropriations bill, and the proviso was vetoed, and the veto was sustained by the legislature. The next mandate to discuss is the autism benefit, as well as oral anti-cancer medication study and law. The autism benefit takes place over time. There was multiple years of study and review by the legislature. In 2010, Senate sub for House Bill 2160 required the Healthcare Commission to provide coverage for services for diagnosis and treatment of autism spectrum disorder and any covered individual whose age was less than 19 years during plan year 2011. There were also limitations on benefits and services that were prescribed. The Healthcare Commission was asked to submit its report on March 1st, by March 1st, 2012, and again report to the legislature with information that included cost impact utilization for what it had taken to provide that coverage in its plan year 2011. The legislature was permitted in the legislation to consider in the next session, following the receipt of the report, whether to require coverage for the autism spectrum disorder in any individual or group health insurance policy or other plan that would be subject to Kansas law on or after July 1st, 2013. Senate sub for House Bill 2160 also required all group or individual health insurance policies and those contracts that I've mentioned previously to provide coverage for certain prescription drugs that provide coverage for prescribed orally administered anti-cancer medications that are used to kill or slow the growth of cancer cells on a basis that's no less favorable than intravenously administered or injected cancer medications that are covered as medical benefits. So this was setting up essentially an issue of equity. If insurance covers it in a certain manner in one way, it should be no less different. It should be no less favorable than if it were covered in another manner. The Healthcare Commission, pursuant again to 40-2249A, was required to submit its report to the legislature that indicated the impact of the provisions for orally administered anti-cancer medications, what those had on the plan, and again, including data on utilization and costs of the coverage. The report was also, again, as it had been for the autism legislation, to reflect any additional utilization and cost data and whether that proposal should be considered again in the plan or whether that should be considered by the legislature. It's important to note that the Healthcare Commission can and does adopt benefits that may be in addition to those prescribed in Kansas law. They opted to continue coverage for the autism spectrum disorder coverage in the plan for not only plan year 2011, but also for plan years 2012 and 2013. In June of 2013, the Healthcare Commission authorized a permanent autism spectrum disorder benefit. The 2014 legislature again considered coverage for autism spectrum disorder in House Bill 2744. With amendments that were made both in the Insurance Committee, the Committee of the Whole, the bill passed the Senate and was signed into law. The bill required, subject to limitations on benefits and services provided, health insurance coverage for the diagnosis and treatment of autism spectrum disorder in children under the age of 12, and also created the Applied Behavioral Analysis Licensure Act, and that would apply to those certain providers who would be making services available for children who qualified under the benefit. This required the state employee plan, subject to the mandate, to update its benefits coverage for plan year 2015 to reflect the changes that had been included in House Bill 2744. The next look that we'll take as we continue this timeline of review was in the 2017-2018 biennium, and there's both study and special committee to note for this particular biennium. The House Committee on Insurance held hearings on two benefit mandate bills. The first was House Bill 2103, which apply to amino acid-based elemental formula. So a formula food for certain individuals who have certain digestive disorders and conditions, generally occurs in children. The second was House Bill 2021, and that pertained to coverage for hearing aids. No formal committee action was taken during the 2017 session. However, a study from the State Employee Health Plan was requested relating to House Bill 2103 to provide more information on the economic and social impact factors associated with the requirements of KSA 40-2249. Also considered during the interim special committee was telehealth and telemedicine legislation. Looking specifically at the amino acid-based elemental formula, following the receipt of the State Employee Health Plan report, the House Committee on Insurance recommended a substitute bill that limited the coverage of the formula to the State Employee Health Plan enrollees for a 1 year or that test track period in plan year 2019 and required a report to the 2020 legislature. These provisions were enacted in 2019 Senate Bill 348. And 2018 Senate Bill 348. That report was submitted in March of 2020, and it was made available to the House Committee on Insurance. It indicates in 2019, the State Employee Health Plan had 4 members for whom had prior authorizations for this formula had been submitted. One of those requests met the guidelines for coverage and was approved. This member submitted one claim for a total amount allowed of $203.80. Given the size of this group, the State Employee Health Plan has elected to continue this pilot program. It's in the form of a rider of coverage. They've continued it for plan year 2020. So they are continuing to gather data on the coverage of amino acid-based elemental formula. In terms of telemedicine, the 2017 Special Committee on Health did not recommend the 2017 legislation that had been introduced on the topic, but instead recommended the introduction of comprehensive telemedicine legislation in 2018. The Kansas Telemedicine Act, Senate sub for House Bill 2028, provides that coverage for a healthcare service delivered via telemedicine is not mandated if such service is not already covered when delivered by a healthcare provider and subject to the terms and conditions of the covered individual's health benefits plan. I promise we're getting close on the timeline. We're now to 2019-2020 biennium, and we'll be looking at amendments to both existing mandates and coverage requirements. In addition to that legislation that was highlighted in Table B, there was legislation introduced to expand existing mandated benefits, breast cancer screening, and mental health treatment. Senate Bill 464 would have required a health insurer that provides benefits for diagnostic breast cancer examinations to ensure that the cost sharing requirements and treatment limitations that are applicable to a diagnostic examination are not less favorable than those requirements and limitations that apply to a screening examination for an insured patient. This particular bill died in Senate committee. House Bill 2459 and the companion bill, Senate Bill 249, would have amended provisions in the Kansas Mental Health Parity Act that previously applied to the coverage of mental illness, alcoholism, drug abuse, or other substance use disorders to expand the coverage associated with the treatment of mental illness or substance use disorders. Among its amendments, the bill would have required insurers to provide coverage without the imposition of prior authorization, concurrent review, or retrospective review, or any other form of utilization review for the first 14 days of medically necessary inpatient and 180 days of medically necessary outpatient treatment and services provided in network. The bill further designated those amendments to the Act as the Christy L. Bennett Mental Health Parity Act. Following its hearing in the House Committee on Insurance, House Bill 2459 was assigned to a subcommittee for further review. The respective bills died in committee. And I want to note, before we get to 2021, there's some information in the briefing book article relevant to the Affordable Care Act in essential health benefits. And I'm going to preface those by saying we need to recognize the changing environment in Washington, D.C. So I am looking for some further information from NCSL and some other sources on how the Affordable Care Act and essential health benefits will be viewed going forward. That said, what is currently present law under the ACA does not directly alter or preempt Kansas or other states that require coverage of specific benefits and provider services. So those mandates that are already part of the law are not affected. However, the law does subject future federal regulations by the Department of Health and Human Services. They were directed, the secretary, to determine essential health benefits that would be made part of qualified health plans that are available in the exchange marketplaces and were required to provide coverage of beginning in 2014. You will see a list of 10 general categories. Among those are ambulatory patient services, maternity and newborn care, prescription drugs, and laboratory services. Women's preventative health services were separately defined by federal regulation in August 2011. And under the ACA, starting in 2014, I do want to note that there was a requirement if a state law mandates coverage that's not included in this list of essential benefits or already not present in law, the state would be required to defray any additional costs for those benefits for its exchange enrollees. A benchmark plan was created, and some states opted not to provide a recommendation to HHS, and therefore HHS assigned states the benchmark, the largest small group plan as its benchmark. There's just some comment there on what the benchmark is. And again, in terms of more recent developments, states have been permitted to maintain their benchmark plans over the years with CMS. So that brings us, Mr. Chairman, to 2020 and the interim. And committee members, you will recall Representative Epley appeared before the committee and discussed the topic briefly of what are called PANs and PANDAS. And so it's important to note that the LCC, this interim, approved a one-day meeting of the House Committee on Health and Human Services during this interim to further study pediatric acute onset neuropsychiatric syndrome, or PANS, and pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or PANDAS. And the meeting was held on December 14th, 2020. The House Committee had previously held an informational briefing on this topic at its regular meeting on February 4th of 2020. And a report has been provided. The report outlines testimony from a psychiatrist, physician, immunologist, parents of children, and persons who have been affected by PANS or PANDAS, information on the condition, including those personal experiences, treatments that have been effective, and the associated cost of those treatments. And I would note, committee members, I'm happy to make available this report. There were some information presented in the report, and the findings among the report, the committee concluded it heard testimony from those conferees that Kansas needs greater awareness of the condition, more education of its providers, and expanded payment sources for the treatments discussed, including a state mandate payment for insurance reimbursements. Enactment of state insurance mandates, the report continued, is a complicated issue requiring review of the Federal Patient Protection and Affordable Care Act requirements for state general fund payments, statutorily required cost-benefit analysis, and test tracking of a new benefit mandate on the state employee health plan. The report continues. In addition, state mandates cover only insured products, so self-insured groups may be exempt under ERISA, and other groups and associations may be exempt under federal short-term limited duration plans or exempt under state law. The committee continued, stating it recommends the 2021 legislature review the insurance implications of any proposed payment mandate on both the public and private payer communities, and it directed its report to a number of committees. Finally, Mr. Chairman, that does bring us to 2021. And I'm just going to review a few bills that either directly relate to creating mandated coverage or create an exemption from those statutes that we've talked about today that require review or test tracking. Senate Bill 48, and a bill that has been introduced in this committee on Monday by Representative Finney, and it was RS 0421. Are a reintroduction of the Senate Bill 464 discussed previously regarding diagnostic breast cancer examinations to make sure that cost sharing requirements and treatment limitations were no less favorable than those that already exist for screening examination for an insured individual. I will note in Senate Bill 48 and RS 0421, I have not verified, but in Senate Bill 48, the language in provision B, subsection B states that provisions of KSA 402248 and 402249A and amendments thereto shall not apply to this section. The next bill is House Bill 2073 that was introduced in this committee and is assigned to this committee. It has a companion bill, Senate Bill 82. This is the Christy L. Bennett Mental Health Parity Act that was previously described. And I would note again that the House Committee on Insurance this past session had a subcommittee that, in addition to the information reported to the committee, there was additional questions and information requests that were addressed at the subcommittee level. We've talked about PANS and PANDAS. House Bill 2110 is in this committee as well, and it would require the Healthcare Commission provide coverage for the diagnosis and prescribed treatment of PANS, PANDAS, and it does require reporting to the legislature on or before March 1st, 2023. So this would require coverage in the state employee health plan during plan year 2022. House Bill 2129 is also in this committee, and this bill requires, beginning in plan year 2022, that the Healthcare Commission implement coverage for tobacco cessation benefits. A report is required from this commission on or before March 1st, 2023, and the bill further states that the report shall be submitted in the manner and include the information required by KSA 40-2249A. And the final bill, well, I guess there would be two. House Bill 2157, which was heard today in the House Committee on Health and Human Services. I'm including it on this list because it relates to limitations on the use of step therapy protocols. And it specifically creates an exemption from the statutes pertaining to the submission and consideration of mandates before the legislature and the test track. There was also a bill introduced today in chamber, Mr. Chairman, House Bill 2206, and those are some amendments to the Telemedicine Act. And so with that, Mr. Chairman, we have now journeyed through health insurance mandates and the more recent review from 2009 to the present. I'm happy to stand for questions at the appropriate time.
Thank you for that overview, and a very detailed topic. Your clarity and tone made it possible to get through that, so I really appreciate your presentation. Committee, are there some questions? I would continue on the discussion towards the end, and thank you for the overview of the bills. Have some of these then completed the impact study as I look at particularly the 4 bills that could be before our committee, or do you have that information?
No, there has not been a formal impact study that I'm aware of. The studies that we have seen relate to orally administered anti-cancer medications, autism spectrum disorder, and then more recently, the elemental amino acid food formula bill. We have seen those studies. Now, at the time that we do have hearings, like with the Mental Health Parity Act, there would be testimony from proponents, and that would be information available. But I'm not aware of a more formal study on a bill like that topic or another bill introduced.
So thank you, and I had the benefit of talking with the ranking some also. So the first step after passing a bill is to do the impact study assessment. And then after that impact study assessment, we move to the state health plan. So we aren't looking for them to complete that study prior. We say, okay, we want to look at this. They do the study. We bring that back, consider it, put it in the state employee health plan, and then confirm if we want it to move forward from there. Is that the process?
That's the process, and as you all noticed, I highlighted some plans where there have been attempts and some have been successful to put the study first, get that study completed so that the parties to the bill could bring that information back to the legislature and again seek a mandate. But in accordance with the law, that is the traditional path you have described.
So thank you, but if someone wished to follow the other steps, they might have that option to complete the study and then move forward. So as I look, thank you, on the PANS and PANDAS, you'd mentioned something that was coming up for the state employee health plan potentially in 2022. I was trying to fit that into that process.
Mr. Chairman, that is how the bill is drafted. So the bill is seeking information from a test track or study so that there could be information made available to the legislature for future consideration. So this is simply putting the study into the law, putting that study before the mandate itself passed.
Thank you. Representative Neighbor.
Thank you for your wonderful, as usual, report. But I think the, not the carrier, but the bill originated with Dr. Epley to begin with. And in talking with him, I think he thought that if it was presented before the insurance committee, that we could then hear it and then request the impact study. Is that how you're reading or in your conversation with him? Because if we did that this year, it would put it into a study next year.
That's correct. The bill suggests that there will be a study that would be conducted if you pass the bill, that would be conducted starting with plan year 2022. And so that is how this particular, and then you would receive that impact and data and utilization from the plan year 2022. You would receive that report no later than March 1st of 2023.
And that would probably fit House Bill 2129, tobacco cessation, the way that bill is written.
It's written in a similar manner as
Okay.
well.
And is the diagnostic breast cancer bill written in that same form? So there's 3 of them?
That bill exempts from the provisions of the test track and mandates review. Okay. And there is, I would note this is one where, you may view this as an expansion of an existing mandate, just as you may with mental health parity. That's how just how you may wish to review the bill, because there is already breast cancer screening language in a mandate.
Thank you so very much, and thank you, Mr. Chairman.
Representative Bishop.
Thank you, Mr. Chairman. I have a question also about the impact study. I just came from Health and Human Services, and where we were hearing the test track, not test track, the step therapy issue, and there was testimony that a cost-benefit study had not been conducted. And so I want to clarify at what point does the relevant law make that necessary? Because I also heard conversation just a few minutes ago that it's after the bill has been passed that the study is conducted.
So this is one of, sir, Representative Bishop, committee members, the step therapy bill itself creates an exemption from the state mandates and test track requirements. If it were following the protocol for mandate review, it would first be in a bill to require the study in a certain plan year, and then the report of that plan year data back to the legislature by March 1st of the next year. And then the following year would be the traditional timeline for when that bill would then be introduced.
Thank you.
Further questions, committee? Representative Dodson.
Thank you for that detailed report. My question has to do with kind of how we do the fiscal side of this. Can I assume that we look at how many people would be impacted, what the cost of treatment and medication would be for a year, and then consultation with the insurance providers to see what a premium impact that would be?
Yes, that's a good assessment. The Healthcare Commission, for the example, when they looked at the autism spectrum disorder coverage, they took into account what they believed utilization would be. As the legislature considered the mandate and before we had any data, one of the things that was looked to was the incidence, what the ratio or incidence of occurrence of autism spectrum disorder among individuals under the age of 12, and there had been a separate under the age of 18 that was originally considered. And so that incidence was then applied across claims data and utilization that was known. So as we learn more about autism or more individuals were classified in that broader spectrum, that did have a direct impact on costs.
Thank you. Thank you, Mr. Chairman.
Further questions, committee? All right. Representative Croft.
Thank you, Mr. Chairman. Just two quick things. One is, did you say that a cost-benefit analysis has to be done before the bill is approved or after the bill is approved?
So if you are following KSA 40-2248 and 2249A, it requires that that study be done prior to the mandate itself being enacted into law. So you put the test track first and put the study first. You receive the data on or before March 1st, which would give you a chance possibly to pass a bill yet that next session, or more likely it would be reintroduced in the following session, and the parties to the bill would have the cost and utilization data.
Okay, so it sounds like then that you do the cost-benefit analysis first, you do the test track, and then you pass the bill.
Yes, and as I mentioned, there have been some exceptions, but that is traditionally the method that's prescribed in statute.
One question. And earlier you said something, and I just want to make sure I caught this. You said a mandate has to deal with treatment for service that is to a significant portion of the population, and that that self-insures and short-term limited and TRICARES and all those others are not included. But then you said that fully healthcare insured plans, like our state falls in. I'm a little confused as to how many are we actually talking about here when we're talking about these mandates. It almost sounds like a small population, a small amount.
It is a growing smaller group since I first worked with some of these mandate statutes. So it does not include Medicaid, Medicare, those supplemental benefit plans, those ERISA plans, so your insurers who are your employers who are using self-insured plans. It does include generally the state employee health plan, your municipal group funded pools, your group and individual policies. It would include policies on and off the exchange that are considered fully insured.
But as you said, it's becoming smaller and smaller. So it seems like that's almost a conflict with a significant portion of the population. I guess I'm just having trouble resolving that. And our health plan for the state actually is not in there. It's just 1 year it's in there, and then we have to decide if it stays. Is that correct?
Yes, and generally they are included. There would be very few examples where they would not be included. But yes, they are your representative group for the testing. I will note, you make a good point. This review law was passed in 1999. And as I had indicated there in the table of the benefit mandates, you may have seen that several were adopted immediately prior to that point. And so those social and economic impact factors were established at that time and have not been updated.
Thank you. And Mr. Chair, I want to note that she did say it might be a good point.
Thank you. I may go back just because I think I'm being dense. the fiscal and social impact study, I was trying to get that order when we talked about PANs and PANDAS. So there's a cost study that's done before we enter into anything. Is the fiscal and social impact then the next step after we do that, or is that the step prior to passing the bill?
The study in the state employee health plan will answer most of those questions on economic and social impact. And so in the PANDA, the mandate itself is not included. The mandate is the portion that's included is to get the data using the test track. And then there's permissive language to the legislature that may then, following the report on March 1st, 2023, consider the adoption of a mandate.
Are there other questions, committee? Other points for clarification? Some of you want to go yet deeper into this? Beyond all clear. Okay.
No, sir.
Thank you. Seeing no further questions, thank you for the overview, and hopefully we'll be better at knowing what questions to ask as we approach any potential future topics. So I appreciate that. With that, committee, for today, we are adjourned. Do think if you have any bill introductions, get those up right away. And then as you have bills that you wish to have considered, I can only assure you that we cannot consider them all. We would have 5 more meeting days and a day to work some final bills as we approach the next deadline. Thank you. Have a good weekend.